Welcome back to the deep dive. Today we're tackling a really complex area of pharmacology, trying to make it immediately accessible.
That's the goal.
We're diving into immunosuppressant drugs. Think Chapter 48 from a major pharm textbook. We're aiming this squarely at anyone needing a clear, solid grasp of this absolutely critical drug class.
And it is critical because fundamentally we're talking about overriding one of the body's core functions, telling self from non-self.
Right.
When that goes wrong, like the immune system attacking a transplanted organ, a graft, or even attacking the body's own tissues in autoimmune diseases like RA or Crohn's, well, that's where these drugs come in.
Immunosuppressants.
Exactly. Drugs that suppress T lymphocytes, mostly.
And the stakes here are just enormous, aren't they? For transplant patients, this isn't temporary, it's lifelong.
Lifelong. And therapy can easily run over $10,000 a year.
Wow. Plus the constant risks, organ rejection on one side, drug toxicity on the other. It's a tightrope walk.
It really is.
So our mission today, unpack the mechanisms, look at the specific drugs, and really focus on those crucial nursing considerations.
Right. The aim isn't just to, flatten the immune system completely. It's about selectively suppressing those T lymphocyte cell lines
Okay.
to stop them from triggering the immune response that causes the damage, basically creating a pharmacologically immunocompromised state.
So the main uses we think of are preventing organ rejection, kidney, heart, liver transplants,
The big ones?
but also treating those autoimmune conditions, psoriasis, rheumatoid arthritis, things like that.
Yes, they have broad applications there too.
Okay, so let's break down the main players. You mentioned 4 major classes, excluding glucocorticoids, which we've covered before. What are they?
We usually group them by how they work, their mechanism of action. So first up, you have the calcineurin inhibitors, think cyclosporine, tacrolimus.
Okay, calcineurin inhibitors.
Second, the antimetabolites. Drugs like azathioprine and mycophenolate fall here.
Antimetabolites, got it.
Third, there are the mTOR inhibitors. That's sirolimus and everolimus, relatively newer class.
mTOR inhibitors.
Right. And fourth, the biologics. These are often monoclonal antibodies. Basiliximab is a key example.
Basiliximab. Okay, 4 classes. So 4 different ways to essentially put the brakes on the immune system. Sounds like managing that combination must be tricky.
It can be, yeah. Understanding how they work is key to understanding their side effects and interactions.
Let's dig into that then. The mechanisms of action, the MOAs.
How do those first ones, the calcineurin inhibitors, cyclosporine and tacrolimus, how do they actually work?
Okay, so think of T cell activation needing go signal. Calcineurin is an enzyme involved in producing that signal.
Right.
These drugs, cyclosporine and tacrolimus, they block the phosphate that's needed to make something called interleukin-2, or IL-2.
IL-2. And that's important because
That's IL-2 is like a key messenger, a cytokine. It basically shouts the order for T cells to activate and start multiplying like crazy.
So if you block IL-2 production, you effectively cut off that multiply now signal for the T cells.
So you're silencing a key command in the immune army. But how do you know how much silencing is enough or too much?
That's the constant balancing act. It's why we monitor drug levels in the blood so carefully, usually trough levels, the lowest point before the next dose.
Right.
Too low, and the immune system wakes up, attacks the graft rejection. Too high, and you risk serious toxicity, especially kidney damage. We'll get more into that.
Okay. So that's calcineurin inhibitors. Now, what about the antimetabolites, azathioprine, mycophenolate? So they work differently.
Yeah, they take a different approach. They're essentially counterfeit building blocks.
Okay, fits.
They mimic the natural purines needed to build DNA and RNA. T cells need to multiply really fast during an immune response, right?
Makes sense.
Well, these drugs stop that. They inhibit cell proliferation because the T cells can't synthesize the genetic material they need to divide.
So they jam the cellular copying machine, basically.
Pretty much, yeah. Stops them from making more T cells.
Okay, and the mTOR inhibitors, sirolimus, everolimus, where do they fit in?
mTOR, that stands for mammalian target of rapamycin. It's a complex signaling pathway inside the cell that controls growth and proliferation.
Right.
Sirolimus and everolimus block this mTOR pathway. By doing that, they prevent the T lymphocytes from getting activated and growing. It's like flipping a different switch, maybe a bit further down the line, that tells the cell line to expand.
Got it. So different point of intervention. And the last class, the biologics, like basiliximab, you mentioned is a monoclonal antibody. That ximab ending is a good clue.
It is, yeah. Basiliximab works very directly. It actually physically blocks the receptor for IL-2 on the T cell surface.
Ah, so instead of stopping IL-2 from being made, like the calcineurin inhibitor.
Exactly. It stops the T cell from even receiving the IL-2 message. It's
Yeah.
like it locks the door so the message can't get in.
Okay, that framework is really helpful. 4 classes, 4 different strategies. But now we need to get into the nitty-gritty, the individual drugs, because that's where those clinical pearls are, the things that prevent serious errors. Let's start with azathioprine, brand name Imuran.
Okay, azathioprine. It's an antimetabolite, kind of a workhorse drug, used a lot for kidney rejection prevention, but also for severe rheumatoid arthritis.
Right.
One key teaching point for RA patients is patience. It can take like 6 to 8 weeks to really see the benefit.
Good to know. But
Yeah.
what are the big risks?
The big one is the black box warning for bone marrow suppression.
Okay, that sounds serious.
It is. Means it can lower your white blood cells, that's leukopenia, and your platelets, thrombocytopenia, which, skyrockets the risk for bad infections and bleeding.
Wow.
And it's also linked to an increased risk of developing lymphomas and other cancers down the line.
So right away, that screams monitor closely. Okay, next up, cyclosporine. Brands like Sandimmune, Humoral, Gengraph, a major calcineurin inhibitor. And here we hit a huge safety issue, right? The formulations.
Oh, absolutely huge. This is like non-negotiable for safety. Sandimmune, Nerol, and Gengraph are not interchangeable, period.
Why not? They're all cyclosporins.
They are, but the way they're formulated drastically changes how the body absorbs them. Nerol and Gengraph were specifically designed to have much better, more consistent bioavailability compared to the original Sandimmune.
Okay, so better absorption with Nerol and Gengraph.
Right. So imagine switching someone from Nerol to Sandimmune, even at the exact same milligram dose.
Their blood level would drop.
Precisely, because less gets absorbed. And that drop could be enough to trigger organ rejection.
Wow. And switching the other way, from Sandimmune to Nerol.
Could cause levels to shoot up, leading to toxicity. So anytime a patient switches between these brand or generic Generica, you absolutely must monitor those trough levels very, very carefully.
That is such a critical point. What else with cyclosporine? Black box warnings?
Yep. Also carries black box warnings for renal impairment, kidney damage, plus liver injury, and increased risk of skin cancer.
Okay, lot to watch for. Let's shift to another antimetabolite, mycophenolate mofetil, brand Celcept, Myfortic. This one has some really significant black box warnings too, especially around pregnancy.
It really does. The warnings are stark. Increased risk of congenital malformations, birth defects, and spontaneous abortions.
Wow.
So effective contraception is an absolute must for female patients of childbearing potential during treatment and for a period after stopping.
For how long after?
For up to 12 weeks after therapy ends.
Yeah.
And beyond that, mycophenolate is also linked to lymphoma risk and something really scary called progressive multifocal leukoencephalopathy, or PML.
PML, I've heard of that. It's bad, right? What is it exactly?
It's a rare but devastating viral infection of the brain. Affects the central nervous system, causes progressive damage, often debilitating, can be fatal.
That's terrifying.
It is. Its inclusion in the black box warning just highlights the profound risks that come with deep immunosuppression. And just like cyclosporine, the different brands here, Celcept and Myfortic, are not considered interchangeable either. Adds another layer of complexity.
More potential for error. Okay, what about administration specifics for the others? Basiliximab, the biologic, you mentioned it can cause a reaction.
Yes, cytokine release syndrome. It happens because the drug causes a rapid dump of inflammatory chemicals, cytokines.
Yeah, it feels like.
It can mimic a severe allergic reaction or anaphylaxis, fever, chills, fast heart rate, trouble breathing, feeling generally unwell. It can be quite severe.
So how do you manage that?
Because the risk is known, patients are almost always pre-medicated, usually with IV corticosteroids, before they get the basiliximab infusion to dampen that reaction.
Makes sense. Okay, and finally, tacrolimus, Prograf, and sirolimus, rapamune. One's a calcineurin inhibitor, the other an mTOR inhibitor. What's the shared concern with them?
It's mainly about cumulative toxicity, largely because they both hang around in the body for a long time. They have really long half-lives.
How long?
Sirolimus is like 60 to 80 hours. Tacrolimus can be up to 61 hours.
Well, that is long.
Yeah, so the drug can build up. And there's a specific interaction rule if they're used with cyclosporine, particularly sirolimus.
Okay.
Sirolimus must be taken 4 hours after the cyclosporine dose. Not together, not before. 4 hours after. Otherwise, you get pharmacokinetic interactions that can bump up toxicity.
4-hour rule. Got it. Okay, we've seen the power these drugs have, but also the risks tied to each one. Let's talk about the universal dangers now. The things that apply across the board because you're suppressing the immune system.
Right. The number one overarching risk is that the patient is now, medically immunocompromised, meaning they're wide open to opportunistic infections. These are infections caused by bacteria, viruses, fungi that a healthy immune system would normally swat away easily. But now they can become serious, even life-threatening.
Constant threat. And the other big one?
Increased risk for certain cancers, especially skin cancers, so sun protection becomes really important, and lymphomas.
Okay, infection and cancer risk are universal. What about specific organ toxicities that are really common or dose-limiting?
The big one, especially for the calcineurin inhibitors, cyclosporine and tacrolimus, is nephrotoxicity, kidney damage. It's often the main factor limiting how high a dose can be used.
So the drug that saves the kidney can also damage the kidney?
Ironically, yes. It's a major challenge. We also see metabolic problems. Something called post-transplant diabetes mellitus can be triggered by corticosteroids, but also by cyclosporine and tacrolimus.
Diabetes, okay.
And cyclosporine specifically is kind of notorious for two cosmetic but still bothersome side effects. Gingival hyperplasia, which is overgrowth of the gums,
Right.
and hirsutism, which is excessive hair growth.
Gum issues and hair growth. Got it. Now, that narrow therapeutic window we keep mentioning, this makes drug interactions incredibly dangerous, right? Especially with that cytochrome P450 system involved in metabolism.
Absolutely critical. This part is mandatory patient education. Anything that inhibits that P450 enzyme system is going to cause trouble.
Inhibits, meaning it slows down the breakdown of the immunosuppressant.
Exactly. So the drug stays in the blood longer, levels go up, risk of toxicity shoots up. Common culprits are certain antibiotics like chlorthromycin, antifungal drugs like fluconazole or ketoconazole, and even some blood pressure meds like verapamil.
Okay, so those increase the risk. What about things that decrease the effect?
Those are the P450 inducers. They speed up the metabolism, breaking down the immunosuppressant faster.
So drug levels drop too low.
Right. And that risks organ rejection. Examples here include seizure meds like phenytoin and phenobarbital, the antibiotic rifampin.
There's a big one, is an herbal one.
Yes. St. John's wort. This is a huge one. It's a potent enzyme inducer.
Outpotent.
Potent enough that there are documented cases where people taking St. John's wort had their cyclosporine levels plummet, leading directly to acute organ rejection.
Wow, just from an over-the-counter herb.
Absolutely, it has to be avoided. And then there's the cardinal food interaction. Grapefruit juice.
Ah, yes, the classic.
Classic for a reason. It inhibits the metabolizing enzymes in the gut wall. It can increase cyclosporine and tacrolimus levels by anywhere from 20% to a staggering 200%.
200%.
Yeah. So, no grapefruit or grapefruit juice ever while on these meds. Also need to watch high potassium foods like bananas and tomatoes with cyclosporine, as that can worsen nephrotoxicity, and high-fat meals can boost sirolimus levels.
The bottom line seems to be, talk to your provider before starting anything new, drug, supplement, even major dietary changes.
Precisely. No guesswork allowed.
Okay, this leads us straight into the nursing process.
Yeah.
Given the lifelong therapy, the multiple drugs, the toxicity risks, the nurse's role here is just immense, isn't it?
It's absolutely central. Starting with assessment, you need thorough baseline data. Vital signs, weight, of course, but then detailed system assessments looking for early toxicity signs.
Like what specifically?
Checking renal function BUN, creatinine levels. Watching hepatic function liver enzymes like ALT, AST, bilirubin levels looking for jaundice. Monitoring cardiovascular status, blood pressure, checking for edema, any heart rhythm changes. And CNS changes, any tremors, confusion, potential seizure activity.
And you mentioned some drug-specific baseline checks, too.
Yes. For cyclosporine, because of that gingival hyperplasia risk, you need a really good baseline oral assessment. Look at the gums carefully.
Okay.
And for azathioprine, with that bone marrow suppression risk, you're closely tracking white blood cell counts, WBCs, and platelets. There are specific thresholds.
Clearly.
You need to contact the prescriber if the WBC count drops below 3,000 per cubic millimeter, or if platelets fall below 100,000. Those are definite red flags.
Red flags noted. Okay, moving to implementation. What are the absolute must-dos for giving these meds safely?
Timing. Timing is everything. These drugs have to be taken exactly as prescribed at the same times every single day. Consistency is key to maintaining stable blood levels.
So in the hospital, nurses need to be rigorous about scheduling those doses precisely.
Absolutely. No around lunchtime dosing. It has to be specific. And for administration itself, some quirks. Oral cyclosporine solution, it can be mixed with milk, chocolate milk, or orange juice to make it taste better,
Okay.
but it needs to be drunk immediately after mixing. And here's a weird but vital detail. Never mix or drink it from a styrofoam cup.
Styrofoam. Why?
The drug actually adheres, it sticks to the styrofoam wall so the patient doesn't get the full dose. Use glass or another material.
Wow, that's specific. Good to know. Any safety tips for tacrolimus?
Yes, huge potential for error because of its narrow therapeutic index. It comes in 0.5 milligrams and 5 milligram capsules.
Oh, easy to mix those up.
Very easy, a tenfold error waiting to happen. So extreme vigilance needed. Always double check the strength and always use a leading zero for doses less than 1 milligram. Right, 0.5 milligrams, not 0.5 milligram.
Prevents confusion.
Exactly. And be aware that tacrolimus, the immunosuppressant, has often been confused with tamsulosin, used for prostate issues. Sound alike, look alike errors are a real risk.
Okay, and generally, oral forms are preferred over injections.
Whenever possible, yes. Simply to reduce the risk of infection that comes anytime you break the skin barrier with an injection.
Makes sense. All right, finally, patient teaching. This is lifelong. What are the core messages?
Number 1 is infection avoidance. This has to become a way of life.
How so?
Avoiding crowds, especially during flu season. Meticulous hand washing. And knowing the signs of infection, fever, sore throat, chills, fatigue, and reporting them immediately to their provider. No waiting.
Okay, what else?
We mentioned contraception mandatory for female patients during therapy and for 12 weeks after stopping. Also, regular self-checks of the mouth for white patches, which could indicate oral candidiasis, a common fungal infection.
Good point.
And the absolute golden rule: never ever stop taking the medication unless specifically told to by their transplant team or physician. Stopping abruptly is almost guaranteed to lead to organ rejection.
Cannot emphasize that enough. Okay, this has been an incredibly dense, but I think really vital deep dive. We've hit the 4 main classes: calcineurin inhibitors, antimetabolites, biologics, mTOR inhibitors, and we've hammered home those critical clinical pearls. The cyclosporine and mycophenolate formulations aren't interchangeable.
Crucial.
The need to watch WBCs with azathioprine.
Essential.
And the absolute ban on grapefruit juice and St. John's wort.
Non-negotiable. You know, getting immunosuppression right is really a triumph of pharmacology, but it only works with absolute precision, exact dosing, perfect timing, and that constant vigilant monitoring for toxicity, especially kidney damage, and for any sign of infection.
It really highlights the delicate balance. You know, the immune system evolved to protect us, and here we are needing to intentionally suppress its most basic functions lifelong, just to allow a life-saving organ to survive. It makes you wonder, what's next? What breakthroughs in research might eventually let us achieve graft tolerance without needing this level of full-body, blunt immunosuppression and all the risks that come with it? That's the hope, right?
That is absolutely the long-term goal. A huge challenge, but the ultimate aim.
Well, thank you for sharing your source material and walking us through this complex topic today. We really hope this deep dive gives you, our listeners, the clarity and the comprehensive understanding you need for safe practice.